Today on the podcast, we had Dr. Verma, who is our first YouTube doctor who is not afraid of the cameras. We had on the show, talked a lot about what it's like running his own clinic and why he decided to start his own clinic instead of going down just the doctor route, working in a hospital group. Hopefully you enjoy.
All right, so yeah, I started my journey to cheers. I started my journey to starting my own private practice. It started mainly when I actually was in medical school. I was going through rotations. I wasn't having a confident feeling of how the hospital structures were set up. And I saw a lot of my mentors as outpatient physicians that own their own practice having a little bit more control of their practice. And I felt like that was more inspiring to me of how I could help more people. And as I got deeper and deeper into my residency and fellowship, I realized this is more and more what I wanted to do. And when I was going out for the job opportunities in my field of interventional pain and musculoskeletal health or pain management, I wasn't finding the practices that would allow me to have the autonomy that I would like to help my patients the best that I saw fit. What I was seeing, especially as the years went on, and more so now, is how much each of these places were looking for certain metrics to try to hit their goals of X amount of procedures, or we don't want to do that procedure because it doesn't reimburse well, or we need this much revenue this month, or we want you to do this much RVUs. And it just, all that didn't make sense. So I was really encouraged to start my own private practice. I started in 2021 and it's been quite a journey. It's as much work as people would think it is. And I put in all the work and put in all the effort. And obviously, I'm not where I want to be, but it's a continuous process of growth and discovery and learning. And I find it very encouraging. And in the past year or so, I've been moving more to focus my practice on regenerative medicine, such as platelet-rich plasma, mesenchymal stem cells, and other fitness and longevity. We'll call longevity as a blanket term in this case. Um, of really looking at the patient as a holistic and like, hey, what happens when I turn 65 or 70 years old? How am I still going to be able to play with my grandkids, go out golfing, go hiking? And that's really what I'm trying to focus my practice now because I'm seeing that there's a lag time of what patients want when they're younger and what they actually get when they're older. And I'm trying to fix that gap.
Yeah. And you mentioned something that I thought was interesting that, you are managing this practice. I thought it was really interesting. You probably have a personal life, I imagine. You have the content, the social media stuff. Then you're seeing patients and managing the clinic. So I'm curious, what is that like? My first question.
Yeah, I think it was not always like this. Everything take some sort of sacrifice. At the beginning, I was sacrificing a lot of my free time. I wasn't doing as much content production. And then over the years, as we started getting better systems in place for my practice, I was able to produce more content and put stuff out on LinkedIn or my YouTube channel or on Instagram. And now, not all of this is directly for patient engagement to try to see me in the practice. A lot of it is just basic education. I just want to get the word out there and try to help people. Now, if that's parlays into patients coming to see me, then great. But that's not necessarily the primary goal of most of what I do. And I also take into heart the War of Art by Stephen Pressfield. I don't know if the listeners are familiar with his book, but it's a fantastic book. And he was an artist, an author, a struggling author for many years. And then later on in his life, he kind of realized like you just need to show up every day and put in the work, even if that's a little bit of work every day to try to make your dreams and your goals come true. And again, my practice isn't where I want to be, and I still have to make some sacrifices and change some things up. But I am juggling all these things of running my practice, making sure that the P&L statements look okay, making sure we're profitable, making sure my staff is paid, making sure we have all the supplies here. It's a lot to juggle, but once you get the systems in place, it becomes a lot easier.
Yeah, and that definitely is kind of close to me. I haven't told you anything about what we're doing at Caesar Health, but everything we're doing is around clinic admin and clinic management and revenue cycle management and trying to make it easier for physicians. So definitely uh, on board with that. So I noticed that you attended medical school in the Caribbean. I kind of wanted to start as well with that. Like, what was that like? And then what was it like, going from your Caribbean medical school to residency?
Yeah, so I think the Caribbean medical schools get a lot of negative connotations. Um, they will sometimes claim them as, hey, these are the individuals that could not get into United States med school, so they must not be good enough. And I can understand that. I can see that point. And they're also, when you graduate from a Caribbean medical school, you're considered an international medical grad. So it makes it more difficult to get into residency. Not impossible, but more difficult. So it was actually quite an invention. The reason why I chose there was because I kind of graduated off cycle from Ohio State University, and I would have had to wait another year to start medical school, or I could have started on an off cycle at St. George's Medical School. So instead of waiting a whole year and going through a round of interviews and all this, I was like, I just want to get started. So when it came around, I went to actually I started my first year in Newcastle, England, when my first year was there, and we did our first year of medical school bookwork. And all intents and purposes, we had the exact same textbooks that all the other medical schools in the United States use. It was maybe been taught in a slightly different manner, but they're basing everything off the U.S. textbooks. So I don't feel my education was lacking in that sense. And in fact, we did a lot of study work with these books and a lot of small groups and a lot of peer mentorship groups. And I felt like I got a really good education. After you beat the curve of, hey, this is medical school, how do I even learn to study? And it took me about 6 months to figure that out. And once I did, wasn't easy, but it definitely made it more palatable of, hey, I can actually do this. And then my second year of medical school was in St. George University, and similar. We used the exact same textbooks. We had a lot of very intense small group sessions, mentorship led sessions, and just a lot of studying. So me personally, I'm the type of individual that needs to kind of buckle down, uh, remove external distractions and learn that way. I learned very well with using, friends and studying in small groups, but it's one of those things you can go a lot further by yourself, but you can get a lot more depth when you're with people. So I had to do a mixture of both. Now, a lot of my friends, they would enjoy going to the beach on the weekends or maybe going out to eat a few times during the week. And I wasn't really like that. I was kind of hunkered down, which for better or for worse, it was a good opportunity for me. And then the benefit of St. George University, the school I went to, they have contracts with certain schools in the certain residency programs and hospitals in the United States that allowed us to do our clinical rotations, the third and fourth year of medical school in these hospital settings. So therefore, we got our education at hospitals in the U.S., such as in New York, California, Michigan, a few other states, in Florida, a few other states. And so we had the same training as far as third and fourth year as our colleagues, and we're actually standing shoulder to shoulder with our colleagues from the United States schools. So it was a great experience, and I think I might have taken it for granted a little bit, but it's definitely something that made me the physician I am today.
And then the YouTube channel, of course, is things I didn't learn in med school. So that being said, what did you not learn in med school?
Yeah.
I
So
should.
obviously that's a little tongue in cheek. What I did realize is when we're spending most of our time in medical school, we're learning a lot of the book work. We're learning pathophysiology, pharmacology, the algorithms, and memorizing tons and tons of data, being able to read and analyze research papers very quickly and very effectively. But what we didn't learn was, how do I run a business? How do I operate as a manager? How do I bill for my medical services? So that's kind of where that project started. And now it's kind of evolved into pretty much anything I want to talk about when it comes to medical terms. And that does include, like, I hear a lot nowadays of people saying, oh, we didn't learn any nutrition or we didn't learn any exercise physiology and stuff in medical schools. Like, maybe I remember learning this stuff because I was really passionate about it. and I paid attention to those classes and I did the extra work to read it. Um, but I remember those things. I guess other people don't because it's such a small part of their medical school curriculum. But those are kind of things I talk about in my on my channel, and I also talk about other lifestyle and again, we'll use a blanket term longevity recommendations of, hey, this is how we can live better lives day to day. And we're not talking about biohacking. We're talking about the very simplistic things of keeping stress low, eating well, exercising regularly, having good social connections, sleeping well, et cetera, et cetera.
Yeah, I definitely am on board with that. I remember I had an ex-girlfriend visit me and she was saying to me, like, she was angry with me and she's saying, your life is so easy. It's so stress-free. It's so simple. I was like, well, yeah, it's like that way on purpose. It's intentional. I don't want to have
Yeah,
any stress in my life. Um,
that's
so
fantastic, though.
then
That's how it should be.
that's how it should be. Well, are you feeling stressed at all or what's your stress situation?
Yeah, I would love to say that I'm not stressed, but that's just a lie. I mean, there is a little bit of stress that is naturally going to happen in your life. You just have to learn how to mitigate stress in stressful situations. I also have to continuously tell myself and tell my patients that it waxes and wanes. It peaks and it valleys. You're never going to just continuously go up and to the right. You're going to kind of go into that curve of up and down until you kind of figure things out and you feel more confident with yourself. So yeah, and definitely for the first few years, my stress levels were way higher than they are today. I wasn't really sure, hey, where's the money coming from? Is it going to come in? What happens if I have a down month? What happens if one of my staff members is sick? Like all these things would stress you out, and you're constantly thinking about the practice. Now I've taken a lot of steps to help myself with a lot of journaling, meditation, spiritual work, working
Mhm.
with talk therapy, cognitive behavioral therapy, just to try to help ease down some of these tensions. And obviously, I like to spend time at the gym and do other intentional walks and that kind of stuff to help keep my stress levels low.
Yeah. So the clinic was founded in 2021. What was kind of the eureka moment that this is, and also this is like the post-COVID environment. What led you to make this decision to create the clinic?
I think it was really when I was interviewing places for a job opportunity. The places I went to, I didn't feel like I was being respected for my knowledge and expertise in the field of interventional pain. But I would probably trace it back more to when I was in my residency. I did a rotation with a sports medicine doctor who focused a lot on regenerative medicine. Um, and when I did the rotation with him, it kind of opened up my eyes to there is a better way to practice medicine than what the institutions are trying to make us believe and get us stuck on their payroll. So once I kind of saw that, I was trying to figure out how I could get that implemented into my life. And but it wouldn't be one eureka moment. It was a combination of these small things that happened throughout my life that made me realize, hey, this is what I really want to do, and this is what I'm passionate about. And I think the other thing is I realized I like to build things and give advice on things and guide people more than I like to just treat and churn, which sometimes that's what it feels like in some of these other environments.
We'll get into that. We'll get into that. It's on the list.
Yeah.
So yeah, on the website, it says you deliver medicine the way it was meant to be practiced. So what is that to you?
Yeah, I think it comes down to first off having that emotional connection with your patient. Um, I don't have to try to pump a patient in and out. We'll talk about that later, as you said. But I try to, sit down and say, hey, what's going on? What's going on outside your pain? How's your life? Are you exercising? What's your diet look like? And I give useful tips, and sometimes I give out guides, like handout guides to, hey, this is the most evidence for these supplements, most evidence for this kind of diet, anti-inflammatory slash Mediterranean diet, some sleep tips. et cetera, et cetera. And then we can start focusing on their pain and try to figure out what's going to be best for them. Not everyone can afford regenerative medicine treatments because those are self-pay as of right now. I tell them like, if we have an option that's covered by insurance, I'll gladly walk you through that. But of course, when we do talk about that, we have to be conscientious that these things that are covered by insurance, we'll say steroid injections, we know they're actually toxic to the body and to the cells, and maybe not the best thing to do repeatedly over time. If we want to hold our Hippocratic oath of first do no harm, well, in my book, we could potentially be doing more harm than good in the long run if we continue with steroid injections. So I kind of have to walk them through that. I tell them why some of the oral medications they're taking, like non-steroidal anti-inflammatory medications, are not that great for you because not only does it increase your risk of ulcers and gastritis and et cetera, et cetera, it can cause kidney damage, irreversible kidney damage, but there's also enough evidence more recently that shows it increases your risk of heart attacks and strokes. And those are not things to sneeze at. So I have to walk patients through this quite frequently because they're not getting that education when they go to their primary care doctor who says, "Oh, we'll just put you on, a leave and we'll start a steroid injection." They're just doing that for the pain relief, but not getting that overall picture of, hey, what can we better help serve your body?
And I noticed that you are strongly against giving opioids to patients. Could you elaborate more on that?
Yeah, when I was doing my residency, that was actually about the time that the Sackler family was starting to get heavily investigated and was actually in court for their um, contributions to the opioid uh, epidemic pandemic, as it were, around that 13 to 2020 timeframe. And I'm also from Marion, Ohio, and that was a city that was actually hit very, very hard by opioids, and it still kind of is. And when I got deeper into the research, we started realizing that there's actually no evidence for opioids for chronic pain. Now, that evidence is kind of murky right now because there's a lot of pain doctors out there that will prescribe it, and I'm not against them prescribing it. I just said, hey, I'm not trying to do that for my patients, given the other side effects when it comes to hormones, immunology, addictive qualities, and other issues. So I want, again, to that holistic approach, like this is the reason why those aren't good for you. Never going to sit here and judge someone that might have been put on it or need it for their pain, but that's just not where my practice focuses on.
And I think this is kind of an interesting topic. What happened with this opioids and this family? Like, what is the story with that?
Yeah, I mean, it's definitely a fascinating story. There's some documentaries on Hulu and I think one on Netflix, a book called Empire of Pain. But essentially, what happened is the Sackler family was a family that was very big into the pharmaceuticals, and they had the geniuses behind a lot of the major marketing for pharmaceutical medications in America. I won't get to their very, very far past, but their more recent past, they were essentially such a blockbuster market drug that they came out with that they were able to rewrite some of the papers out there suggesting that painkillers are not addictive. And that was their selling point. And they went to conferences all across America and they were paying for doctors to essentially go out and to basketball games, front row tickets to concerts. We're talking millions and millions of dollars into doctors' pockets for advertising for these medications and secondarily, essentially prescribing these medications. So because of that, and because of some other things, the Sunshine Act was implemented, saying that no longer can pharmaceutical companies do any of that. They can really pay for educational meals, but they can't pay for conferences. They can't have these big seminars anymore. They can't pay for basketball tickets or even small gifts. So that was kind of a big reason why a bunch of doctors out there, not knowing any better because they didn't do their own research, said, hey, these opioids, they're not that bad. We're going to put our patients on it. And then they realized how difficult it was getting their patients off these medications in the long run. And I think that's where we're at today because the FDA kind of swung too far the wrong direction and made it almost impossible for the patients that might need it to get it. And again, I don't really have a uh, either way for me. I mean, if patients need it, they need it, but they need to go through the proper vetting process. It's not something that can just be prescribed off the bat just because you're in chronic
Mhm.
pain.
Yeah. Some guy walks in, hey, can I have some opioids? Yeah, sure. Yeah. Have fun.
Right, right.
Yeah.
And no
Got it.
longer are those days, and it might have been a little easier in the past, but we're starting to realize all the long-term negative outlooks on opioids. So I hope I did a little bit of justice telling the story, and I think that hits the highlighted points.
Yeah. So on the website, you say you accept all major insurance, et cetera, et cetera. But I noticed there's a, cash pay seems to be a theme. There is this kind of thing where there is a lot of cash pay going on. Why would someone who has insurance might have to pay in cash when they show up at the clinic?
Multiple reasons. I think I'll start with a story of I have an individual recently. He was experiencing severe back pain, and um, he was like, "I will do anything to get out of this pain." And I said, "Well, obviously, we can do this, and this." And I explained everything to him, and he said, "Okay, well." I've heard that epidural steroid injections are pretty effective. I said, yeah, they can be, but we need to make sure we're in the right area and targeting the right nerves, et cetera, et cetera. So he said, okay, what do I need to do to get this epidural? Well, we need to go through 4 weeks of physical therapy. We need to get an MRI. We need to make sure that you've failed at least one or two medication classes. Um, we need to ask the insurance company if this is even something that they're going to pay for. So these are all these steps that we have to do, and it might take 6, 8, 12 weeks to get all these things wrapped up into a pretty bow to present to the insurance company. When this patient is going to spend hundreds of dollars on physical therapy copays and out-of-pocket payments, hundreds of dollars on their MRI, hundreds of dollars on their um, procedure itself. These all have associated costs with them, plus this time of suffering, plus the cost of medications. So you wrap that up, you're like, hey, that's a few $1,000s that and time wasted. Versus, okay, I know that this facility will take a cash payment for your MRI, and then you review that MRI, and as long as I feel it's appropriate, we can do an epidural steroid injection without jumping through all these hoops. Now, I'm a big proponent of doing physical therapy, chiropractic work before and after any epidural steroid injection or any procedure that I do, really. But the idea is this person is like, hey, I'm willing to do anything because I'm in so much pain right now. Um, and I think that's where the evidence is lacking because we don't have great evidence of timeline of time to treat and how much people suffer. And I feel like that's doing a disservice to people. And then the other end of the spectrum is patients have had these procedures done before, and they're like, hey, I don't want to go through all those hoops. I just want to get the procedure done. And that's understandable. And then the third thing I want to talk about is just regenerative medicine, as briefly mentioned before, not covered by insurance. So I think it's a good option for a lot of patients that have some of these degenerative disorders and sometimes in acute pain.
Can you give some examples of like regenerative medicine,
Yeah.
etc.?
So regenerative medicine has another buzzword term that we're using a lot in society. Um, in the US, we're really only allowed to use two specific forms of regenerative medicine, or as we'll call them now, orthobiologics. Um, and allowed to use platelet-rich plasma, which is drawing out your blood and spinning it down and throwing out most of the cells, but maintaining the platelets and some growth factors, and then re-inject that into areas of, we'll say, mild to moderate, either arthritis or tendonitis or tendinosis. Um, Sometimes we'll do them into some ligaments. Sometimes we'll do it around nerves with some perceptual processing to call plasma lysate. And these can be pretty effective. I don't want to say they regenerate things, but I would like to say that they restore at least some function in the area, and they also help repair a little bit of the area too. And then the secondary form of regenerative medicine or orthobiologics is mesenchymal stem cells. Now, these are stem cells either derived from your fat or bone marrow. And we are allowed to minimally process them same day only. We can't exponentially grow them. We can't put them in petri dishes. We can't add external factors. And after we reprocess those, we can re-inject those into the same similar areas I discussed before. Now, these have a little bit more of a robust signal because they actually have some stem cells in there. And it's similar. Our goal is to help repair and restore the area. And we see under in the petri dishes under lab microscopes of how this does cause some changes into the environment to make a less inflammatory environment.
Got it. Yeah, interesting. This is kind of like the future stuff, I'm always interested
Yeah,
in.
yeah.
Yeah. You said on LinkedIn, insurance system grinds doctors down, strips away autonomy, and rewards volume over judgment. I was wondering if you wanted to elaborate on this. Is kind of the part we get to hate on insurance together. It's the best part of the podcast.
Yeah. I think it's definitely could be its own podcast conversation, but what we're seeing is as physicians, our reimbursements are continuously getting cut year after year after year. And at a certain point, I think they were saying by 2030, an orthopedic surgeon to do a knee replacement is going to be paid less than minimum wage in time of hours it spends that they have to see the patient before, do the knee surgery, and their follow-up, which is under the global period, so they'd see him for free. So just think about that. You're getting paid less than minimum wage to do a knee surgery, which is an absolute necessary procedure for hundreds of thousands of patients yearly because they can't walk. And the insurance company is going to find ways to not pay you, delay payment. And because of this, as practitioners, you're forced to see a higher volume of patients. It's not abnormal for a knee surgeon to do 17 to 25 knee replacements in a day if they have to because of those demands. Now, granted, they're in the operating room from 6 a.m. till 6 p.m., but they're there all day busting out these surgeries just to make sure that they can make enough money. So that's one big thing the insurance companies is taking away the expertise that we spent so long doing. Um, the delays of payments, the denials of payments, and the clawbacks of payments. They'll come down to the years down the road and say, "Hey, you did not make this one requirement. We're going to ask for our money back." And then you have to go through appeals. You have to ask like for for your staff to spend more time to get those appeals overturned. And then for authorizations, we're spending more and more time for more and more patients to get authorizations for these procedures. I'm going through a issue right now where I need an emergent or MRI for another patient because I'm suspecting a surgical pathology and I need to get to a surgeon. My billing company, my prior auth company, they can't get through to anybody. They're just talking to an AI bot online, or
Mm.
the website that they're supposed to commit it to is submitted to is online and it's AI bot ran. And even the phone that they call AI bot ran. And we can't talk to an actual human being on the other side. So when people are out here suffering and the physicians are wanting to do the best thing that they can for the patients are the one that suffer as well. So it's really taking away our autonomy. It becomes frustrating. It becomes really that grind of, hey, what am I really doing? Am I actually helping people the way I'm designed to be helping people?
Yeah. And that's kind of one of the things we're working on here at Caesar Health is we have clinics where we're, shameless plug, but we have clinics we're working with that are cash pay only. And it's like there's a moment where you can actually create a more efficient clinic because you don't have to hire a bunch of staff to do insurance billing, that you can actually start offering good value with cash pay and just not have to worry about it. One of the
Exactly.
things we're doing here. Yeah.
Yeah,
Uh,
that's awesome. I'm looking forward to learning more as the years go on and the days go on about what you guys are doing.
I can show you after the call some cool stuff if you're interested in. It's
Yeah.
optional. Optional. Um, optional plug. Do you know what pajama time is?
I don't know. I mean, I can make a guess, but I'll
It's like a physician goes home after a hard, long day's work, puts on their pajamas, and then just does billing and revenue cycle management all night. Uh, is that something that you're doing or no? I think I lost you, Dr. Verma.
All right, I don't know. Sorry about that. Not sure whose end
All
that was
good.
on.
But like, do you? How much of your time? The pajama time question. It's like how much of your time goes towards revenue cycle management?
Yeah, so um, for me, thankfully, I do have a trustworthy billing and team that's more of a mom and pop shop. Granted, those mom and pop shops are going to actually charge a little bit higher, but you have that one-on-one. Hey, I can text and call at any time. But and that helps relieve some of the stress that takes off of it. But I think that's the big question is like how much time am I spending at home working on my practice? And of course those are things that you go home and you look at and you'd like to just sit back at the or just spend an hour at the office time of like, hey, let me make sure all my financials look good and my revenue looks good, et cetera, et cetera. I probably spend about an hour to 2 hours a week cleaning things up that I wish
Mm.
I didn't have to. And that's I've fortunate enough I can spread out my schedule enough where I can do it during my office hours or before I see patients. But you're right, like that is something that's very vitally missing in our field and in medicine. And there's thousands of companies that say, "Oh, we can do a good job for you. We can do a good job for you." I don't know. I don't have enough experience with all these other ones, but I'm willing to explore options that are going to make my revenue cycle management easier. But also, as you talked about earlier, is like that's what makes the allure of cash payment so much better. Get the payment in. I'm willing to see the patient. They're more willing, they're more invested to get the procedure or treatment done at that point. And they're
Yeah,
not
one
going
of
to
the
cancel.
things. Oh, sorry.
Nope, that's it.
One of the things we're building at Caesar Health is like a revenue cycle management AI to help you with your claims. And it's funny, like you show some, older doctors usually this software, and they go, "Oh, I don't know, I don't know if I should." If you went to United or Blue Cross and you said, "I have an AI I built for you that will increase your denials by 30%," they're going to be like, "Let's go, hand it
Yeah,
over."
yeah.
Uh, we're behind, and that's kind of what the Caesar Health Project is about.
Great.
Um, so you moderated a session on financial wellness for medical students and doctors, and we've already kind of touched on it. They don't teach business in medical school. Um, what is there a conversation to be had about this? You think with business and medicine?
Yeah, I am part of the tribe, the movement, whatever you want to call it, that encourages medical students, residents, fellows, and attendings to start their own private practice to help shift the favor back into private practice field. I think right now it's too heavily weighted towards hospital systems. And these hospital
Mhm.
systems will grab you and hold on to you tight. And they'll promise you all these bonuses and structures, but at the end of the day, they're sliding in 2 or 3 or 4 extra patients a day just to make that same money that you were making before. And they will do it in a very, oh, well, this is what we need to do kind of way. I think we need to educate our young minds, our young physicians of this is where the money actually comes from. This is how much of your dollar is actually goes to you for seeing a patient versus administrative costs, hospital costs, et cetera, et cetera. So at the end of the day, when you look at a piece of paper and say, for example, if I see a Medicare patient for new patient 99204, I get about 120 some dollars, give or take, just depending on the contracts, whatever. Well, for me, I know where all that goes. I know at least 30% is going to go to my overhead, at least 30% goes to improvements, and then I get the rest for profits for the practice. For a employed physician, all they see is an RVU value and they see how much RVUs they make. But if you actually do the calculation, it's like you're getting 30 to 40 bucks for an RVU, and that's not very much when some of these RVUs aren't even paying a full RVU. So we really need to educate these individuals of where is your money going? You're doing all this work and getting, and it doesn't even go to you. I also think it's just beneficial in general to have business classes. Um, Medicine is a great calling for many, many people. But for me, I feel like I'm always going to want to help people. I'm always going to want to see patients. But I think there's also going to be other entrepreneurial activities that I want to do. And you see a lot of physicians go into real estate, um, other businesses. And I think the reason is because they realize that being a physician in itself is rewarding, but they're missing out on the revenue that they could be making elsewhere. And that's just in a goal to be financially independent and financially successful down the road.
Yeah, and it kind of ties in that you said this on LinkedIn. So doctors are rewarded for seeing a lot of patients, both financially and with excellence awards. However, true excellence is boring, unsexy, and hard to quantify. Um, so what do you do to make your clinic more holistic? With that being said,
Yeah, so I'll kind of do it the reverse way. It's funny because there's a lot of companies out here that want to give a center of excellence for these practices that do X amount of procedures in a year, say 100 procedures. Now,
yeah,
that doesn't mean that all those 100 patients needed that procedure, but that doctor wanted that center of excellence and their name slapped on a website. And I think it's hilarious because I don't know. If I help 100,000 patients, that's way more meaningful to me than treating 100 patients, getting my name on a website for this one procedure.
yeah,
Now, if I'm very specialized and very skilled in a single procedure and the known world renowned for that one procedure, and patients come all over the world to see me, that's a different story for sure. But that's where my approach comes in of sitting down and talking to the patient and giving them all the options and guiding them to what might be the best option. And I tell them, hey, if I'm not the right person for you and or I can't figure out how to help you, I'm going to help you find someone that can. And that does happen a few times a week of saying, I don't have anything in my practice that can help you, but let me help you find someone that can. I also think that we quite frequently ignore the metabolic health of our patients, and we're willing to just throw them into surgery because their basic EKG and their basic blood work came back normal. But if you actually look into the depths of all this stuff, we know that the more metabolically healthy you are, the better chances you're going to have in surgery. And we also see that in the orthobiologic world. Some great
yeah.
papers just came out saying we really want to focus on making your health as optimized as possible because that's just going to make your outcomes better in the long run. So that's kind
Yeah,
of what
we
we
did an
focus on.
entire podcast on that actually with Dr.
Oh,
Scott Russo. Shout out. His whole clinic is
awesome.
all about that Mediterranean diet, which I know is something
Yeah.
you mentioned as well, and preparing for surgery. So,
Yeah, that's great. And I'm glad that more physicians are seeing this, but that's not something you can just talk about in a 7 minute, 10-minute patient interaction. You need to sit down and break it down why these things matter.
yeah, yeah, 100%. It's kind of an interesting thing I've seen you talk about kind of in multiple spots. So, if in the biohacking community, peptides are a big thing. And if I walked into your clinic right now and I said, Dr. Verma, I'm going on peptides, what would be your response to that?
So it's multifold. I think one, I always have to give them or any patient, hey, this may or may not be beneficial for you because we don't have enough studies. I think that's always the best place to start. That's number one. Number two is you want to make sure you're getting from a reputable source and not just some rinky-dink pharmacy that's trying to make a bunch of money because that does happen, and that those are the ones that cause complications.
Mm,
Now, I follow a lot of the bro science, as you will, and they do talk a lot about their benefits. So I'm cautiously optimistic, and I tell my patients I'm cautiously optimistic about it. And I would say, which ones are you interested in getting on? I can tell you what those are expected to do, and that's about as far as my recommendations can go. I sometimes will say, hey, what's the website you're using? Let me vet it myself and make sure that they have some of the licensure that's appropriate. But even at the end of the day, unless you're testing them yourselves, you don't really know what you're getting. So you could be just spending $150, $200, what have it, on just bacteriostatic water at the end of the day, and you don't know what peptides are actually in there. But I am very cautiously optimistic about the ones that are supposedly going to work in the long run, and I'm hoping that we get there in better studies someday.
Yeah. So we don't like to run these podcasts too long. What do you think is the future for Essential Sports and Spine Solutions?
Yeah, so phase one of my future is getting out of the insurance model and doing all self-pay. And we're going to and ramp up our regenerative medicine services, focusing more on PRP and stem cells, but also adding in our MLS laser, which I didn't talk too much about, but and also shockwave. And these are all soft tissues healing modalities. So that's phase one. Phase two would be adding in the lifestyles, that longevity piece of doing comprehensive blood work, potentially the patients that might need hormone replacement. Not everyone needs hormone replacement, and I think there's a lot of hormone TRT clinics out there that put 100% of their patients on it. Sometimes patients just need a slight shove in the right direction with either supplementation or proper diet and nutrition advice. So that's phase two. Phase three would be opening up a location that actually has a gym or partnering with a gym that we're able to actually go through some movement patterns, strengthening, testing some of those other things that we can't test in a clinic, such as VO2 max testing, DEXA scan, and how our heart rate variability is, heart rate recovery is, and those other health markers that we're not able to capture in a clinic. And then, yeah, mainly just focusing on health and recovery at the end of the day.
Yeah, and I think it's great to get your clinic involved in that world. I think that is the future of healthcare is the preventative side and all that stuff. I want to go on TRT, not now, but like
Yeah,
when I'm 40 or
yeah. How old are you right
something.
now?
I'm
How old are you right now?
27 now.
Yeah. So I think
I look young.
yeah, I
I'm
mean,
shaved.
you're young right now. You have enough chance to optimize diet and exercise. And I agree. I think about around the age of 40, based off of the hormone disruptors we have in society, around the age of 40, everyone should at least contemplate it. And you can go on a low dose and just see how that does for you for a few years. You don't have to go super physiological and get super big, but just that baseline to bump it up a little bit and get you back to normal is
Yeah.
not a bad thing to think about.
Lifestyle. I want the lifestyle to continue, but I
Yeah.
guess a doctor actually told me that I should have kids before I go on TRT. It's like kids first, then TRT after. Yeah.
Yep, I agree. That's probably the best course of action.
So there you go. So if people want to find you, like check you out on LinkedIn, where can they find you, et
Yeah.
cetera?
Yeah, so Nikhil Verma, MD. You can find me on LinkedIn. You can find me on X, Instagram. My Instagram handle is Dr. Envy Sports Spine, Sports and Spine. I think that's my same handle on X. Also on Facebook. I'm pretty active in my YouTube channel, Things I Didn't Learn in Med School with Nick Hilberma, MD. These I'm pretty active on all of them. I'm posting at least 3 or 4 times a week on through the various avenues. And yeah, hopefully you guys link me below as well in the podcast, and people can find me that way too. And I'm always open to DMs, messages. Maybe we're not going to work together, but happy to answer questions. I get on phone calls with a lot of medical students or residents, kind of going through their transition, and I love to do those kind of things for people.
Yeah, awesome. Thank you so much for coming on the show.
Yeah, thank you.